Hello, and welcome to Spotlight Autism. My name is Leslie Grubler, and we have a very special show today. I have an individual by the name of Anne Bridgelall, and she's an occupational therapist. And I know that many of you, when you hear the term occupational therapist, you wonder, what is that? Is that a therapist who helps me with my occupation? That's always the question that seems to come up. But our guest, Anne Bridgelall, will tell us today a little bit about what occupational therapy is. And I know that our families of children with autism are especially interested because it is an occupational therapist's responsibility to use what we call sensory integration techniques with children with autism. Let me tell you a little bit about Anne. She's been practicing for 15 years, having graduated from York College here in Queens. She was employed in Harlem Hospital in the rehab unit as the chief of occupational therapy. She's developed fundamental skills to best treat and help patients progress, which includes fabricating positioning, and she's going to tell us what that means, aids, and assessing and ordering specialized assistive equipment for children. She's worked with mixed caseloads from neonatal to burns and bedside victims, and even those who are comatose. She's joined EI as an independent contractor in 2003. She's a member of the Executive Committee of the United New York Early Intervention Providers and has been working with EI for the last 9 years. So welcome. I'm so delighted to have you. Tell me, Anne, a little bit about what this occupational therapy is all about.
You kind of mentioned occupation, and we are about occupation. It's occupation of everyday life, such as activities of daily living, some people have heard, and that's like self-care, eating, dressing, even going to the store if you're older, play activities, leisure activities, even education, going to school, going to work, pretty much encompasses all the activities of life. So it is the occupation of living.
Ah, so it's the occupation of living.
Of living and living life the best way you can, given what you have.
And so when you think of when you're working with a child who hasn't had really much of a life, right? Maybe it could be a 1-year-old or a 2-year-old or a 3-year-old. How does an occupational therapist make their life better?
Right. Well, knowing what the process of life is, we look at a baby and we say, okay, these are the fundamental movements you require to progress to playing, as another guest had mentioned, to playing, to exploring your environment, to developing skills that will lead to thinking, to making choices, to developing reasoning, and to engaging in different activities as you come upon them, so that you're not challenged without a response. And that's what we focus on, is helping a person from the youngest to the oldest to develop an ability in themselves to get that strength and that skill necessary to live life.
Yeah, so if a child is unable to take care of themselves in a way like lifting a cup to drink, or even holding their own bottle, or even buttoning their jacket or snapping their jacket or zippering, that's all part of taking care of yourself.
Right.
Right?
And what we look at, it's not even the task that you're doing, it's how you're doing it. Because you could zip your jacket up, but can you put your hat on, your gloves on, the rest of it, to take care of yourself, to make sure that you're comfortable and you're also safe from cold, or whatever other measures you need to protect yourself against.
So all of those pieces. So, a child might be able to zipper, but they may not be able to tie their shoes.
To bend down and get back up.
Right. Be stable enough.
Right. And so even from a little baby, as you mentioned, we look at how that baby can roll to get to the bottle that might have slipped out of the mouth, rather than lay there and rely on someone else to come. And that usually, from experience, if a child is there and the bottle has to be placed in a hand, yeah, they could hold the bottle, but if it falls and you can't get to turn to get it, to hold it, to continue to feed yourself, you start developing a sense of anxiety and frustration. Frustration that leads to other frustrations and a dependency. And actually, occupational therapy is about leading a person to more independent living, independent choices and independent actions.
Why is self-reliance and independence so important for a little baby?
Oh, it builds confidence, and it builds a cognitive confidence and also physical confidence. Physical confidence is the movement in a hard surface or a soft surface. Movement with obstacles or without obstacles. It's just basic movement to get you from one place to the next, so that you begin to make choices and you begin to find that you can do things for yourself. And you could see something and you could get to it and you can explore it and you can actually conquer it, you know? Yeah, and you develop a sense of strength, inner strength, and your place in society also. Because, yeah.
So as you grow and you develop this inner strength, I guess what you're saying is that inner strength leads to inner strength.
It builds upon itself, and then others believe in you, and they actually start seeking you out to ask for something. Like parents do that often, I notice. They see a child begin to seek out an activity, they'll ask for something else, another activity, and then that child goes and get that stuff. And then there's an engagement that occurs, an engagement and a connection that builds other relationships and builds strength, and you start feeding off of each other. You know, and it develops the bond that parents need to have with their children and children need to have with their parents.
So you've worked with many different types of children and adults even over the years.
Yes.
And you've seen kids in very horrific settings.
Yeah.
And in horrific situations as well. Where do you feel as though you make the most difference?
I think I make the most difference with the parents who can't really quite understand what is happening to their child. And I'm able to go in and build a rapport from understanding the culture, because I am from a different culture. And I have also taught myself Spanish. So I do have a lot of cases that are Spanish speakers. And so I get into those homes and I just love it because I'm able to connect with those families and give them a sense of hope and understanding of the American culture, the culture that their children will belong to, not the old country's culture. So I'm able to tie it in, and I think those cases I'm really extremely successful with, because the parents start developing their own strength, their own understanding of what is happening with their child, and their understanding that they actually have the skill necessary to help their child to progress and to enter the mainstream world, which is every parent's hope.
Do you think every parent has that belief in themselves? Do you think they have that capacity to be able to connect with their own child and engage? I know so many of the children that I work with, you know, their families have a difficult time relating to their own children. And a good deal of my work is spent with the families, getting them to sometimes even love their own child. What do you see?
What I see is that when I go into a home the first time and a child is there doing whatever movement that's not understood or lack of movement and it's not understood why, I go and from just me and that child, there's an interaction that begins, and I start talking it out, you know, putting words to what's happening. And the parents start turning around and they start standing, looking at me and working with me.
Yes.
I said, did you see that? Do you understand what this is? Why is this happening? And then I start saying, could this be it? And as I put words to what could be happening, the parents are like, oh, and you know what else? And they start adding to that conversation. Yes. And that conversation builds into movement. And that movement builds into that child looking both at me and the parent and saying, why are you allowing this person to do this to me, to make me move, to make me come out of my area where I choose to be? And I see like an awakening happening. You know, the parents actually do start believing, you know, this is possible. And then, I don't know if I'm jumping ahead, but going to the sensory part, which is very big in occupational therapy, we go there and by just simply touching key parts, main parts, and understanding what the responses are. You can say to a parent, see, this is what I will do and this is what's going to happen. And when I do it and it does happen, they're like, oh, it's there? I'm like, yeah, it's all there. It's just waiting to come out. if we can get this child beyond where they choose to be right now. I think it's a choice for the child.
Sometimes it is.
I think,
sometimes it appears that way.
Sometimes it appears, yeah.
Tell me a little bit about what sensory integration is, and why is it that occupational therapists have the capacity to apply sensory integration techniques?
Sensory integration relates to the perceptual skills, and that's like, you know, touch, sense, smell, vision, hearing, those basic senses that if they don't respond the way they should and can tolerate whatever is coming at them at the level that it's coming, it can't be tolerated, then the child or the person tends to have a withdrawal effect, they back down. And there's 3 main areas in that response that's not productive. That's called fight response, where you might see, we're speaking about children, where you'll see the child might hit you, try to bite you, or push you away, or then you have the fright response, which is usually the crying, the whining, the fear. You could see fear, and the pulling away with body language. And then you have the flight response, where there's a turn and a run, heading for the other side. And sometimes you see both or all 3 together very quickly. It can occur.
So I like that, the fight, the fright, and the flight response.
Yes.
And I'm sure that many of our families with children with autism have experienced this in their children, and they just don't know what to do with it. You know, I like to equate it to, you know, sensory dysfunction as, I know that when I walk into my house at night and if someone's cooking spaghetti and meatballs, I know it's spaghetti and meatballs. But maybe a child with autism will smell something and not know at all what it is.
Right.
Their senses are not telling them that what's cooking in the kitchen is something good, something, at least I think it's good, to eat. And it might scare them, and it might make them afraid, and it might make them want to run the other way because they just don't know what this is.
Right. On the other side of that, I've also seen kids where their sense is so hypersensitive that they can tell in like almost a split second. It's almost surreal.
Yes.
What it is and what it requires of themselves to engage in that particular, whether it's food, whether it's sounds, it's colors, touching, textures. They could tell. And as an occupational therapist, because we are focused on the occupation of life, if these simple things at this young age block you, then how are you going to progress beyond this when you have less control? In your home, you have much more control.
Yes.
It's your home environment. It's your safe zone. It's your sanctuary. It's where your parents are, and your protection is there.
Right.
They have you in their best interest, but outside of the home, that might change. You're just a part of one of many. So it's important as an occupational therapist going into a home, helping that child recognizing what we see now as a deficit, what it could mean in the future in a community setting, especially without the parent there.
Right.
And that is exactly what I address when I first go in. It's not about us being here with this child at this moment. It's about helping this child to develop the skills necessary for when we're not there, so that they can regulate themselves in the sensory areas. Regulation, which means that when you get really flustered and you either want to just go down on the floor and, you know, just lay there, or you want to just jump up and scream and holler. It's the 2 extremes.
Right.
If you had to look at a chart, extreme hypersensitivity or low arousal down here, we want to get that child in here. Or if you're down here, you can bring yourself back up. Up here, you can bring yourself back down so that you can re-engage and you can refocus and you can accept the challenge and you can progress.
I remember when I was working with a new child in early intervention, and I came to the door, rang the bell, and the child came to the door, opened the door, looked at me and said, "Go away." That was my first encounter. And when I walked into the house, I said, where's your daughter, to the mom? And she said, oh, she's in the closet. I said, oh, she's in the closet? And she said, yes, that's where she goes. So a lot of our children with autism, they seem to seek out these very closed-in, dark places.
Yes.
Tell me a little bit about what that's about. What does that mean?
And also to go into the dark, secluded, very limited input, very limited stimulation. You get that at night also. Parents sometimes saying, this child wakes up at night, prefers the night versus the day. The daytime is all, very repetitive stuff, very predictable behaviors. But at night, there seems to be an awakening. Because at night, if you think about it, there's less stimulation. The light, what you see with that light is what you can allow in. But in the daylight, the sun shines on everything. There's reflections, there's sounds, there's people outside, there's horns. There are so many more activities that you really can't control. So what do? You shut down. You lower your ability to take in stimulation from the outside. So I've seen from these children, and you also hear the kids are, it's an aversion. They don't like the sounds of blow dryers or vacuums, or these sounds that are high-pitched and very loud and strong and forceful. Because strong, forceful, loud, that you can't control requires you to have a reaction that might require more reaction, more muscle use, more thinking, more connectivity between your physical and your cognitive state. And so what you find with children sometimes, they're very good at shutting down, it's called lowering the ability to receive input. And
so what would that look like when a child shuts down? What is that?
It would look like, if you're right here and you're speaking, you see the eyes start wandering, you know they're going to a shutdown. Or if you bring an activity in the middle, they'll try to choose one over there or farther away. As you're speaking, shutdown also can be another precursor to shutdown is the fight response, where you might get the headbutt or the tensing of the muscles, you'll feel it, and there's a heating up of the muscle also. So these are all signs, precursors to shutdown coming up. Yeah.
Do you prescribe sensory diets for your children?
No.
Tell me a little bit about why.
I'll go back a little. I've taken the different courses that address sensory integration issues or sensory disorder, and including the brushing, sensory diets prescribed there. Also music. There's a changing of music. There's a special music that they use. What I found through my years of practice and with many different backgrounds, nationality, ethnic groups, it seems to have a predetermined notion of what it is you're seeing, and so you come with a structure, an activity that's already predetermined for this child. I found it was better to go into a home and see what the limiting factors were, and then from there ask the parent, so what do you do when this happens? Brushing, I don't use it, or I don't teach parents to use it, but I do explain to them what it is. And thankfully there's many other therapists out there that took the course and they use it. So I encourage them, if they're really interested in it, to please, seek out the technique from them. But I explain to them what it is that you have to do it in such an exact way with a child that usually when you start, they're kicking and screaming.
So I like what you said about it, and just for our audience who they may never have heard that term, sensory diet, as Anne said, it's usually a prescribed series of activities that a child must do on a regular basis, typically with the parent, in an ongoing way throughout the day. So one part of it might be brushing, one part of it might be listening to music, etc. And I like the way you responded to that, though, by saying that, yeah, it's prescribed, essentially, and that really doesn't individualize the treatment. It doesn't force us to take a look at the child in front of us. and
Right.
take action on the child that we see. How do you know when a child with autism is benefiting from sensory integration? How do you know?
Oh, you know right away. Because you see the kicking, it tries to take life, it tries to get really, the child tries to get tense, but they just relax. The breathing, you'll feel the breathing get intensified, and then you'll hear the shallow, long breaths, and you know there's calm. Visually, remember I said the child will look away, you'll see more of a midline. Midline is extremely important because it indicates the ability to use both sides of your body.
And the brain,
And
right?
the brain, yes. And so that's very important. You'll see the child tolerating, looking in the middle, maybe even making eye contact in a purposeful way to kind of communicate with the eyes. You will hear, as a speech therapist, you hear more babbling, change in the sounds from just long, ah, or scream, high pitch. High pitch usually for me, it's like an alarm. It's like the fire engine sound. It's like, you better leave, otherwise I'm gonna keep doing this, and you won't be happy, because I'm not happy. So you'll see that coming down and just kind of like fizzing out. It just like goes away. And the child will be able, you bring another activity in, and there's more of a willingness to re-engage, and that's how you know that with the technique used, it's working.
You know, I'm always so disappointed in discussions that I have with other therapists about sensory integration because so many don't want to hear it. You know, they say, oh, it's not grounded in research, you know, like other therapies are. And, you know, I'm just not going to use it. Whereas for myself, experientially, over the years, I'm grateful that I've worked with so many fabulous OTs who really know about sensory integration and have been able to show me the benefits over and over and over again. And experientially, I've been able to see the benefits in my use of it in practice as well. Why do you suppose there hasn't been a good research study that has been developed that can prove its efficacy or its value or its worth? Because I think it is a therapeutic intervention strategy that just needs to be out there. Our children with autism particularly benefit from it. But what's your perspective on this?
I've spent many hours thinking about this because from experience, I hear a lot of people say sensory issues. But when you say, what do you mean? There really isn't a conversation after that. There seems to be not too much of an understanding of what you see and how can you treat it? Is it treatable? Are there any techniques out there other than the sensory diet and the brushing and the music? Is there anything else out there that can work? And I think maybe they could start with parents who've gone through, with a therapist who's done sensory integration and modulation and addressed sensory issues, which is pretty much addressing the different senses and seeing why it doesn't want to respond in a certain way. And say, did it work? What was proposed? Could I do it at home? When I did it work? And most of the parents say yes. And maybe ask the parents, what is sensory to you, to your child? What does it look like? And if they can describe it, then it does exist, because they're parents, and they understand the need for...
Do you think, I'm sorry, do you think that most children and family members who engage in sensory integration activities are having fun with it?
Yeah.
Is it fun?
Yes. Yeah, and the fun in it is that what I've seen over the year, and it works with anyone, everyone, even adults, it's touch. It's putting your hands a certain way in, you know, creating that balance that's very important for physical and cognitive and the brain.
So it could even be like when we think about activities, it could be just like a box of rice and beans that a child puts their hands in.
Yeah, I don't even get that far because I just get to pressure in the, for example, the hands are very important, because if you think of a baby, first thing they do is roll over and put pressure on the hands to start pushing up and getting the head control. Why is this? Why is it so important? Because then it goes back to getting this pressure right here goes right back down to the stabilizing centers, I've noticed from the kids. And if a child has delays in grasp later on in life, I always ask, how long did this child crawl crawl, spend time on the tummy, usually it's not too much time. And there is a limiting factor with that. So I go backwards neurologically. I address it neurologically. I kind of awaken those systems. I go backwards and I do what the kids didn't do. And then I see more responsivity to textures, touching, exploring textures.
And even eating.
Even eating, yes, even eating, the oral part. Stabilizing here. Once it's stabilized, there's more of an inclination to try different foods, different textures, because you, as a speech therapist, you could explain better than me. But, you know, the mechanism to handle maybe multiple textures or different types of foods, it requires a certain muscle strength and coordination.
And this whole area is
yes.
like one big sensory palace.
Oh,
you
yeah.
know?
The higher you go, the more sensitive
sure.
it is.
Yes.
Which is why with the fine motor, it is so sensitive because it's higher up. And I usually start working with a child in my sensory approach. It's from working on the balance, standing, you know, the physical therapy part of it. I usually address that. And then I move higher up to the breathing, the posture, and which helps with the shoulders. Which once the shoulders are good, then the hands, you can start working with the hands. And when the hands are good, once you could do this, the eyes come in. Once this can come in, then the head comes up and the mouth comes in, and then everything just connects.
I imagine that this is so second nature to you, that at times
yeah.
it must be difficult to even talk about it.
Yes, sometimes it is, yeah. Once a child is right next to me, it just begins and it progresses, and the parent comes in, and then that parent takes over and they can do what I just did and get the same results and get better.
If you had to share with our parents about, you know, should a family be afraid of sensory integration? If a family came to you and said, you know, I was told that my child has a sensory issue and they have to engage in sensory integration. What is this? And should I be afraid of it? Sounds scary. What would you tell a parent?
Oh, first thing I say, rather than be afraid, fear just blocks you from progressing further and understanding more. So you just say, what is the sensory issue again? Why? When does it occur? How intense is it? Once you start observing and assessing and knowing when it occurs, then you can also kind of interject. You could stop it from getting worse.
I wanted to thank you for being with us today, Anne. I know I've learned so much, and I hope our audience has as well. And I hope that we can have you back here, because I know that you have much more to share. I wanted to take this opportunity to just thank you for teaching our parents about sensory integration, and particularly how it impacts children with autism. And I hope we see you again soon.
Thank you.
So thank you again to Andrew Bauman, and we'll look forward to seeing you again soon.